So here you are watching coblation adenoidectomy in a 9-year-old, 9.5-year-old kid with obstructed nose, recurrent URTI, and you can see the adenoids are almost grade 4. We have given the child some steroids before the surgery so that the vascularity has gone down. Even the size of the adenoids has reduced, and therefore we can do a good work with coblation plasma at the setting of 9 for ablation and 4 for coagulation. The wand is going through the oral cavity, is bent by almost 35 degrees, and the 0-degree endoscope is going through the nose. Now that's the superior boundary. As you can see here, that's the periosteum of the sphenoid bone, which I have not opened. I have reached the periosteum, but I have not opened it up. That's the superior boundary. If I open up the periosteum, the child will have pain because of osteitis. Periosteum is a good cover for the bone, which obviously we do not want to open up. That's the boundary. So we do not want to cross the boundary. We just want to reach the boundary. And now that's the periosteum. As you can see here, completely cleared. There's no lymphoid tissue left on the superior boundary. And now we are just reducing the bulk of the adenoids so that we can go for the lateral and the posterior boundary. So this is the, can you pour some saline? You don't need to take out your scope again and again. You can just ask the nurse to pour some saline. Now, see, this is the eustachian tube opening. This is the torus tuberis. This is a little bit of adenoid tissue in the superior boundary. And as we reduce the bulk, now we'll go for the lateral boundary. The lateral boundary anteriorly is the torus tuberis. You can see some tissues on the torus tuberis. Now I'll very carefully remove only the lymphoid tissues from the torus tuberis, but I'll remain 4 to 5 millimeter away from the eustachian tube orifice. As you can see here, I have not damaged the eustachian tube orifice, but I am removing all the lymphoid tissues. And as we remove the lymphoid tissues from the torus tuberis, I will, which is the anterior boundary, laterally, I'll get into the fossa of Rosenmuller. That's the fossa of Rosenmuller, which is the lateral boundary in the posterior aspect. So see, there is still some lymphoid tissue on the torus tuberis, which I am ablating. And now I am getting into the fossa of Rosenmuller. So while you do this, you also have to simultaneously reduce the bulk of the adenoids so that you can see your boundary in a better way. And as I said, the scope can be defogged by either pouring saline or touching on the tissues inside so that you don't have to come out again and again. Because if you go in and come out, then you damage the mucosa of the septum as well as the inferior turbinate, which you do not want. That's the fossa of Rosenmuller, which is being completely cleared. That's the lateral boundary posteriorly. And layer by layer, we need to remove all the lymphoid tissues over here. That's the buccopharyngeal fascia at the back, which is our posterior boundary. We have to be sure that we do not open up the buccopharyngeal fascia. We have to reach, but not to open. Now, as you can see here, I am almost into the depth of the fossa of Rosenmuller. This is the torus tuberous. A little more of the tissues, but without damaging the muscle into the torus tuberous. And now let me reduce the bulk here so that it does not fall in my way. That's the fossa of Rosenmuller. I do not want to open up the fascia at the back, but at the same time I want to remove every bit of tissue so that it does not regrow. And also to ensure that the child does not get recurrent ear infections, because that's the area adjacent to the eustachian tube. Now you can see layer by layer we have removed every bit of the lymphoid tissue. That's the buccopharyngeal fascia, and that's the fossa of Rosenmuller completely, almost completely cleared. So never ever go blindly. You must see what you are doing. Now you can see the fascia opened up pretty nicely. Fascia reached pretty nicely. You can call it buccopharyngeal fascia. You can call it pharyngobasilar fascia, whatever. Now this is the lower limit, which is the passavant's ridge, and you will see some horizontal contractions over here. So the passavant's ridge is the lowest boundary, the inferior boundary of the adenoids. And once you remove the lymphoid tissues completely reaching till the boundaries, then the chances of the adenoid regrowing and causing any symptoms or causing any complications is very, very rare. All right, so you can see, can you pour some saline, sister? This little blood was from the turbinate, which had to be out fractured to reach. Can you pour some saline? So the left side adenoidectomy is complete. Now, before we go to the right, we will debulk the central part of the adenoids. And you can see how much tissue had to be removed. Unless you remove so much of lymphoid tissues, adenoids are bound to return and create postnasal drip, sometimes obstruction, and recurrent ear infections. All right. Now, this is how plasma actually removes the adenoid. So left side adenoidectomy is complete. You can see all the boundaries. Now I'll come from the right side and do the same work. So thank you for watching the boundaries of the adenoids on the left side.